Yeah. Good evening, respected doctors. I, on behalf of Gennova Biopharmaceutical, welcome all of you for this No Thrombosis National Workshop. We all know No Thrombosis Workshop is a initiative which is basically to take up new cases and ensure that however thrombolysis has been done through them, how does it can be best worked out. To take us through, we have the course coordinator with us, Dr. S. Meenakshi Sundaram, sir. So we all know about Dr. S. Meenakshi Sundaram, sir. He is a senior consultant neurologist in Apollo Specialty Hospital in Madurai. He has more than 20 years of experience in neurology, and he has also participated in research work and various workshops under the neurological department and published many papers. He has a lot of affiliations, particularly from Neurological Society of India, Indian Academy of Neurosciences, and American Academy of Neurology. Sir's major achievement is Gold Medal and Best Outgoing Student Award for the year 2000 from NIMANS, Bangalore. Sir has also got Best Research Paper Award at the 10th Annual Conference of IIN Lucknow 2002. And also, sir has 29 journal publications and 18 book chapters. Welcome, sir, and thanks for being the course coordinator, sir. We also have Dr. K.K. Prachet, sir, who is again senior consultant neurologist at Kongunad Hospital, Coimbatore. Sir is a renowned neurologist with 25 years of clinical experience. Sir has completed his MBBS and MD from JIPMER, Pondicherry. Sir has pursued his DM in neurology from NIMHANS, Bangalore. Sir's area of interest include headache, demyelinating disorders, and stroke. Sir is currently working as senior consultant neurologist at Kongunad Hospital, Coimbatore. Welcome, K.K. Prachet, sir, as being the moderator. Also, we have Dr. Jayanti ma'am, who is HOD and senior consultant neurologist at the Madras Medical Mission Hospital, Chennai. Ma'am has completed MBBS from Kilpak Medical College and went on to complete her MD from Coimbatore Medical College, and ma'am has done DM Neurology from Madras Medical College. Ma'am has served as consultant neurologist at King Khalid Hospital and assistant consultant neurology at King Fahd Medical College, Saudi Arabia. Ma'am has trained and mentored MBBS, DM neurology, psychiatry, neurosurgery, and nursing students. Ma'am has also researched and presented papers on stroke, epilepsy, neuropathy, and neurophysiology in national and international forums. Ma'am leads epilepsy, headache, and movement disorder clinics and participates in neurological awareness and screening camp. With this, we welcome all the faculty and request Dr. Meenakshi Sundaram to take things forward, sir. Over to you, sir.
Thank you very much. Welcome again for yet another program of No Thrombosis, where we learn a lot about thrombolysis, which really has still a long area to go in our country and abroad, I hear. So it's welcome move that we are actually discussing about several cases of thrombolysis. As we all say, that neurology is learned stroke by stroke, and nothing teaches you more than ischemic stroke and where thrombolysis is involved. So with that opening words, I request my co-chairpersons, Dr. Prachet and Madam, to share their knowledge, and then we'll take the case forward. Prachet. Any introductory words, Prachet? Prachet, you are muted. Dr. Jayanti, Madam.
Yes, sir. I would first of all like to thank the organizers, because this is a very important and hot topic. We are always facing emergencies every day, and each case, as you said, is different, and we all learn from each patient. With the increasing incidence of thrombolysis and thrombectomy, I think we will definitely get to learn more and see how best we can save our patients with less morbidity and mortality. I'm glad to be a part of this program today.
Thank you, Madam. Thank you. Prachet, anything, Prachet, before we start? Prachet remains muted. Anyway, thank you. May I invite Dr. Anirban Lara to share the case with sir? Prachet, anything, yeah. Prachet, you are again back.
No, it's fine. We can
start. Anirban sir, could you take us through the case, sir?
Sure, sir. I'll just share my screen. Yeah, is my screen visible now?
Not yet, sir.
Uh, I've gone full screen and I've given the share option.
Same way, sir, as we did just now.
It is visible?
Not yet, sir. Yeah, it is come, sir. Just if you can put
Coming?
it on the full
Yeah,
screen, sir.
yeah, yeah. Is it
Thanks,
okay
sir.
now?
Yeah, fine, sir. Can go ahead. Sir.
Okay. So, shall I start?
Yes, sir.
Yeah. First of all, I would like to thank the organizers for having me here in this, allowing me to present this interesting case of thrombolysis. I also thank the chairperson, sir, and the senior faculty and the colleagues and my colleagues over here. With this, I'll start the presentation. It's a case of thrombolysis in a nonagenarian, uh, so which we did here at Kamakshi Hospital in Chennai. So our patient was a 94 years gentleman who presented with an acute onset of the right upper and lower upper limb weakness with numbness for about 3 hours prior to the time of presentation. He also had a slurring of speech and also had difficulty in naming of things and reduced word output. There was no history of any loss of consciousness, seizures, any visual impairment, or any history suggestive of any facial or any bulbar weakness. He has history of dyslipidemia, but no history of any diabetes, hypertension, or coronary artery disease. So on examination, patients had a GCS of 15 by 15 with vitals were pulse was around 64 per minute, blood pressure was 150 by 80, saturation and respiratory rates were now with acceptable. His height was 172 centimeter and weight was 60 kg. So on CNS examination, patient was alert following commands. His speech was slurred. There was nominal aphasia with reduced fluency. There on cranial nerve examination, there was a right upper motor neuron 7 facial nerve palsy, and other cranial nerve examinations were within normal limits. So the motor system examination showed that the bulk and tone were normal, and the power examination on the right side, the upper limb was 4 by 5, lower limb was 4 plus by 5, and he had a mild weakness of the hand grip on the right side. The left side powers were within normal limits. Reflexes were 2 plus on right and left, both sides, and the right plantar was upgoing. Sensory examination showed an impaired touch and pain sensation over the right hand and an impaired graphesthesia and 2-point discriminations. There were no extrapyramidal or cerebellar signs. He had a hemiparetic gait, and his NIHSS scoring was 8 upon 42, and modified Rankin score was 3 on presentation. So routine blood works were sent with sample collection, which turned out to be mostly within normal limits, except for the lipid profile, which showed elevated total cholesterol, LDL values. HbA1c and thyroid function were within normal limits. So patient was within 3 hours, so he was taken up. We did the MRI stroke protocol, which showed multifocal infarcts in the left, involving the left frontoparietal region, in the post-central and also involving the pre-central gyrus. Acute infarcts were noted. The MR angio did not show any significant stenosis, and the MR venogram was normal except for a left transverse sinus hypoplastic. So with this, the patient attenders were counseled regarding the window period, as the patient had presented to 3 hours, and by the time of assessment, it was 3.5 to 3.45 hours. So we got the informed consent for thrombolysis after explaining the risks of thrombolysis, and we chose to give injection tenecteplase, 0.25 milligram per kilogram body weight. Considering his weight was 60, We gave a 15 milligram dose as a bolus. We monitored throughout the thrombolysis. The neuromonitoring was done. The vitals, GCS, NISSS, pupils, glucose monitoring was done. The patient was shifted to ICU, and anti-edema measures were instituted with 3% saline and head and elevation. And for the first 48 hours, it was continued and then tapered off. So we did a 24 hours check CT. There was no evidence of any hemorrhagic transformation or any significant bleed. So there was a mild development of the infarct in the left anterior frontal region, but the primary area where he had the precentral, that was reasonably spared. So in the post thrombolysis, the outcome was that power improved to 4+/5 in the left upper limb, and in the lower limb it became 5/5 by about 6 hours post thrombolysis, and it was maintained throughout in the initial phase of the hospitalization. His language skills improved within 24 hours to near normal. He had a mild slurring which persisted, but given his age, and he was a somewhat edentulous also, so we took that into consideration. Sensation of the right upper limb, the numbness there was a partial improvement, but he was still having some numbness on examination. So after 48 hours, his MRS score was 2. That was an improvement of 1 from the time of presentation. We had started the atorvastatin, and dual antiplatelets were started as per protocol after 24 hours. And atorvastatin was started along with the initial stroke treatment. Other supportive treatments were continued. Patient was shifted to ward on the day 3 of admission. His vitals were stable. Physiotherapy, speech and language therapy was done. And by 7th day, he was discharged home. On the day of discharge, his MRS was assessed and it was 1. So at follow-up of 90 days, the patient came to the OPD. He was independently ambulant. He had a clear speech and normal language. There was a mild residual numbness which was still persisting, but it was not limiting any activity, no weakness at the time of review. So a brief discussion. Intravenous altiplase was approved by US FDA for stroke thrombolysis in ischemic stroke in 1996. However, altiplase had some challenges to it that regarding the hemorrhagic complications, fibrinolytic efficacy. Sometimes there was partial recanalization in the arteries. In almost like less than 40% cases, there was complete recanalization was achieved. Tenecteplase, which was a tissue-type plasminogen activator, has a better pharmacokinetics and pharmacodynamic properties, and compared to the altiplase, and supposedly has a lower risk of ICH, symptomatic ICH. Hence, it is possibly a better thrombolytic agent. It has a longer half-life and a better fibrin specificity. So there were multiple trials have happened over the years, and I would just mention a few of them. The ACT trial that compared intravenous tenecteplase to altiplase in acute ischemic stroke, it was done in Canada. So they found that there was improvement in the tenecteplase had a comparable improvement. It was non-inferior to altiplase at functional recovery at 90 to 120 days without any significant bleed or any mortality compared to altiplase. A trace 2, which was done in China, again, the tenecteplase versus altiplase had a similar findings. In this study, they had selected patients who were candidates for thrombolysis, but not for endovascular thrombolysis, endovascular measures. And the ATTEST-2 trial was the largest trial in the UK, which happened, and they also found that altiplase and tenecteplase is non-inferior to the altiplase within a 4.5 hours window compared to for stroke thrombolysis. So considering all these trials and others also, the 2023 European Stroke Organization, they have now strongly recommended that the tenecteplase at a dose of 0.25 milligram per kilogram can be used instead of the altiplase 0.9 milligram per kilogram in acute ischemic stroke patients, or even with patients with large vessel occlusion within 4.5 hours of symptom onset. One more trial I would like to bring up is the extend in intra-arterial tenecteplase trial, where they tried tenecteplase versus alteplase comparison before thrombectomy in patients with ischemic stroke, and it compared the efficacy. And it was for in patients with occlusions of the internal carotid artery, basal artery, and the middle cerebral artery were chosen within a 4.5-hour time window. And tenecteplase was shown to increase the absolute rate of successful recanalization by 12% compared to alteplase, so which in a way is a better outcome measure. So in extend intra-arterial TNK, the part 2 of the trial, they compared the two doses of tenecteplase, with some advocating the higher dose, the 0.4 milligram per kilogram versus the 0.25 milligram per kilogram. And the bottom line was that the 0.4 milligram per kilogram did not give any additional benefit compared to the lower dose 0.2 per kilogram. So, as regards the functional outcome, the all-cause death and the symptomatic ICH. So, in the 2019 AHA and ASA acute stroke guidelines, they have chosen the tenecteplase 0.25 milligram per kilogram bolus dose with a maximum ceiling of 25 milligram for bridging therapy, which may be a reasonable option over alteplase, considering the bleeding risks and the efficacy. So the efficacy and safety profile of tenecteplase in patients greater than 80 years old was not clearly established. So there was a study in recently in China in 2024. They did a post hoc analysis from the data from the TRACE2 trial and on tenecteplase versus alteplase for acute ischemic stroke, taking the greater than 80 years age population. I think around 137 patients were selected, and the study showed that tenecteplase in this age group did not have any statistical difference compared to alteplase regarding efficacy and the safety outcomes within the 4.5 hours time window. So a pooled analysis from the extend intra-arterial tenecteplase trials, as well as the TRACE2 trials and all. So they showed that there is less mortality in the tenecteplase compared to the alteplase with patients older than 80 years in the bridging endovascular procedure. So our patient, who was aged 94 years, he underwent a successful thrombolysis with the improvement of the clinical condition and a better MRS score of almost by 2 score levels at discharge. So in conclusion, so IV intravenous thrombolysis is the mainstay in acute ischemic stroke management at the emergency. Although alteplase has been approved by US FDA, tenecteplase is an alternative agent which has better fibrin specificity, lower bleed risk, and has been shown to provide better 90-day functional outcome in the patients with, even in patients with large vessel occlusion. Age is not a limiting factor for intravenous thrombolysis. Tenecteplase has shown comparable results in thrombolysis patients aged more than 80 years compared to vis-a-vis younger individuals. So with this, I think we should be optimistic in treating the acute ischemic stroke patients with IV thrombolysis, and we can choose tenecteplase safely for further measures. Thank you.
Thank you very much, Dr. Anirban Laha sir. Thank you very much. That was a presentation. Highlighted important points were that it was the non-Nigerian who got treated and used tenecteplase in 0.25 milligram per kg body weight. So these are the two things which are highlighted for us. Thank you very much, sir. The case is open for discussion. May I request my colleagues to give their comments, please? Madam, you could just share your thoughts on this case.
Yes, sir. I have a few questions that I have to ask. One thing is, he has told about dyslipidemia in a 94-year-old. Do we have a carotid Doppler and an echo on him, sir? What was the...
We did echo was done, madam. Echo, I think I missed to put up the data of the carotid Doppler and echo. The carotid Doppler did not show any significant stenosis. It was around, there were some atherosclerotic plaques of around 30% stenosis, but not more than 50%. And echo, there was some mild LVH, but no significant intra-arterial, or I mean intracardiac thrombi was not there. We have not
Then
done the
another point that
transesophageal echo in this case.
okay,
Consider
okay.
at his age, we did not do the go for it, the transesophageal echo.
Was there a Holter done, sir? Did he have a paroxysmal AF? Was it looked for at any time?
Yeah, it was looked for. The halter was there. There was no evidence of any major pause, any sinus pause, or it was not there. Halter was within normal limits.
Coming on to the examination part, sir, there is
Yes, ma'am.
patient has had a cortical sign in the form of graphesthesia and 2-point discrimination that he has had a deficiency on the right
Yes.
side. So being a cortical stroke, the most common etiology we would think of, and it was a fragmented stroke. It was not a full, it was a probably a branch occlusion only. So
Yes, ma'am.
would we not think of getting into our complete cardiac evaluation, including a transesophageal? That is one point that I would want to add.
Yes.
Another thing that in your investigations, the hemoglobin was 15.2.
Yes, ma'am.
Is it that he had any other risk factors for this high hemoglobin, sir?
No, ma'am. The hemoglobin was 15.2 at the time of admission, but on subsequently on follow-up, it had settled down to around 13 to around 13, as I can remember. And there was no polycythemia or other evidence at that other evidence of polycythemia. Second thing is, for as regards to transesophageal echo, we had planned it, but the patient attenders were not willing, given his age and the point of needing an endoscopy and all, they were not willing to proceed with it. So that is why we couldn't proceed with the transesophageal echo. And further, regarding the halter was done, and I have told the other Doppler and all.
It is definitely a learning case, sir, because having the age factor of 94,
Yes,
giving it for a patient with high risk of an intracerebral bleed,
yes,
I think we should all go beyond the guidelines and start treating our old people
yes, ma'am.
also
Actually,
without keeping age
I
as a limit.
Yes, ma'am. I think that is the highlight in my case is the
Yeah.
age at which we could take it. And what I would like to highlight here is actually at our hospital we follow a CT protocol, uh, not rigidly, but when we deviate is in these cases, such cases where we would love to have a MRI which is showing any features of any GRE blooming and all. So here actually we had deviated from the usual C where we do a from the CT, we did the MRI stroke protocol brief study to
Okay.
salvage the time. Yeah.
Yes. Thank you, sir. Thank you.
Thank you.
That's it.
A good presentation to highlight the utility of thrombolysis in older patients. One or two comments. Is there any role of mannitol in this patient anti-edema measures? I don't think there is any role of
There's no edema.
Yeah.
So I have not used mannitol. We have gone for 3% saline.
Whatever. Even 3% saline, I don't think is really indicated. That is number one. Then number two, for the youngsters, see in ER, I mean for the people who are just entering the thrombolysis, I'm sure you have done this for the sake of presentation, but in the ER we should not waste time in graphesthesias and things in such situation. Aim main is to reduce the door to needle time. So I'm sure you've done this
I
later.
think,
You've done
yes.
this
Actually,
later.
the presentation, the way the slides are, and what we are doing in the ER is not exactly in tandem. This is for
the newcomer should not get misled and start doing all these things in the ER. In the ER, door to needle time is very, very important. So even a minute should not be wasted. So that can be done later. That has to be highlighted here and not to waste precious time on this. Otherwise, it is, I think, most probably due to paroxysmal atrial fibrillation. If you do a longer holter, probably you'll get some answers.
Yeah.
That is the most likely cause.
Probably a 7 days loop recorder would have
Yes,
been a
yes, yes.
better choice in this case. Yes.
Thank you, Prachit. Today, I think the recommendation is for at least 1 month, correct, Prachit?
Which one? Yeah,
The
correct,
recommendation for
correct.
minimum recording of Holter
Correct.
in a patient who is suspected to have, and at 90 years, the first thing we are going to think of is only
Yeah.
paroxysmal AF.
AF,
So
yes.
practically, it becomes difficult for us to do for 90 days, 1 month, because of the cost involved. But when we talk to them, the initial cost is around 10,000, but then subsequently for 1 week, but then they give it for a lesser price if we have to do it for a longer time. So practically, I've been able to do it for a maximum of 2 weeks. Beyond that, the patient doesn't accept. But one, intriguing thing which I've seen is the use of smartwatches.
Mm.
There are papers about use of smartwatches. Any comment on that, Prachit, you have? For atrial fibrillation pickup, because now we can use this Apple smartwatch, and there are many watches from the Samsung Galaxy. It becomes, quite cheaper for us in the long term, I think.
Yeah, but I don't know. Some cardiologists use it, but I haven't.
There is a full paper in NEJM about this.
Yeah.
NEJM, there is a paper about the use of smartwatches, and now in the market there are availability things. They provide market watches which you can use it and ask them to get it back to you. But difficult for us in private practice to do that, but they are available. That's what I'm trying to tell you. That's one thing. In the elderly age, sir, thank you, Anil Bansal. The elderly age, the problems we'll face is that number one, the cerebral reserve is going to be low for us. Number two, there are complications which can expect in the form of hemorrhage. The reason is because there may be pre-existing ischemic vascular disease which are predisposing them, lot of leukoariosis, cerebral amyloid angiopathy. These are the issues which they are going to face in elder. And finally, the outcomes may not be as good as you see in the younger people. That is the cerebral volume reserve being less. However, I do not believe as of today that the age is a contraindication. Is that correct, Prachit?
Yes,
There is no upper limit cutoff for age. Those
No.
things which are placed are just guidelines for us, which were practiced during a setting of study purpose.
Yeah.
For study, you should have criteria, you use this criteria. But in practice, there is no age cutoff for thrombolysis. Dr. Ichapuria sir has cases of 100 years. I have one of 99 thrombolyzed. So age should never be used as an exclusionary. In fact, in one of the large meta-analysis, it was shown that the elderly people in volume of benefit, they had more benefit with the thrombolysis than younger people because they have more to lose. If you take that factor into your consideration, if that is factorized, then you'll understand that their benefits are much more even than the young people. That's one point we need to really understand. Meta-analysis has clearly shown this, that age people, of course, there is going to be a problem of hemorrhage, which may be more common in them than young people. But age per se will never be a criteria for us to think of not thrombolizing a given patient. That's the current understanding, I believe. And even the latest recommendation 26 also says, is that correct, Prajit?
Yes.
Yes.
So, if I may add, actually, what we all have, I fully agree with you, sir. Meenakshi, sir. So we always have an inhibition. The higher the age goes, we are always careful. We are always wary. It's a general psyche for somebody, even with us doctors sometimes. In but frankly, in this case, there was a triggering factor. Is his daughter wanted the maximum and the best treatment for my father. So that gave us the confidence to counsel her for thrombolysis and explain the risk and all. So I would also thank the daughter that she placed the confidence on us to go ahead with the treatment. So it should always be kept in mind. And as sir was telling, uh, age is definitely not. It has been proved in trials, multiple trials, and the patients benefit. This patient had he landed up with a persistent residual weakness, lower limb weakness, he would have been incapacitated in bed. The falls would have been more common, and his quality of life definitely would have been a different story.
And one intriguing thing in this case is that when you showed the infarct, it's not a big infarct, it's a very small infarct.
Yes.
But the deficits you showed were
Yes.
disproportionately large. Any comment on that, sir? Because
Sir,
aphasia, with that significant aphasia, significant sensory disturbance, significant weakness, with one small infarct which was sitting there. Any comment on that, sir?
Sir, I think that was evolving. I think the stroke was in evolution. So most likely he would have landed up with a larger stroke. So we have there were multifocal actually. So the consider what we also thought of the atrial fibrillation as a cause, because it was not in one. It was a bit, some of the infarcts were in the more anterior section. One was in the posterior post central gyrus. So he was in the evolution phase, I think.
One of the things which is said is that the clinical deficits will far outweigh the radiological deficits,
Yes.
because it estimates not only what is seen on the diffusion, it also estimates the penumbra, the core, everything it deficits. So that's one key reason why we must aggressively go on thrombolyze. But one thing which I have practiced, it's practical, not sure, you have done a 0.25 milligram per kg body using the ACT data. Obviously, we use the ACT data and use for 0.25 milligrams. But when it is 90, I tend to go a bit slow, and I've used even 80 plus. I think a 0.2 milligram will be reasonable. It's my, because our recommendation in our country is 0.2, and there are papers of even 0.1. So when it is there in an elderly people, I would use caution and not go for 0.25 in this case. Prajit, do you think any other, Prajit? Prajit, madam?
I agree, sir. With the older age, I think 0.2 would be a safer dosage. To continue in the same line, this is not related to this case, but I would like to know in patients, elderly patients who have lone atrial fibrillation landing up with a stroke, and if they are on NOAC, what do we do? Are we allowed to thrombolyze? Any comments or learning points?
There are many papers which have talked about thrombolysis in patients who are on NOACs. It is there. And there are many case reports are there. But if you look at even the latest recommendation, when you look at that, it's one of the contraindications listed, madam. 48 hours before, if you have taken, it is listed as a contraindication. Now, in the 2026 guidelines also say that. So difficult to say, but there are people whom in my own group, there are people who have thrombolyzed, and there are people who have been bold enough to give a reversal factor and thrombolyze. So these things do exist, but as of now, we do not know the answer, madam. That's all. It's individualized decision, in my opinion. What would be your take, Dr. Anirban, sir?
Sir, I am conservative in this with NOAX. NOAX, I am conservative.
If the known time is known more than 5 half-lives beyond that,
more than 5, it's yes,
fine.
but it's fine. But
if you have taken in the
within
morning and
24
they have
hours,
come,
no.
probably we won't do it. But you can do it by using a reversal. You can do a prax bind and then actually give them thrombolysis. That has been done on quite a number of patients, and now that andexanet alpha is also available, you can give it and reverse it and do, but very, very expensive to use.
Yes,
And
sir.
I'm not sure
And it
whether
is very
it's really
difficult
a
to
good
procure at the time of, within keeping all the time scales in, and it's difficult to procure and give it, and it is difficult considering that.
Prachet is not there now, is it?
No, I'm here.
Okay, now what is your comment, Ra?
Regarding, sorry,
NOAX.
regarding,
No, there was a talk about, no, you went away, so NOAX, we got disconnected. NOAX and thrombolysis. So there was a question raised about NOAX and thrombolysis. Yeah.
you mean contraindication for
Yeah, whether it is a contraindication, how do you view this? NOAX and giving thrombolysis.
No, I think
Madam has asked, Jayanti madam.
I think no, the recent guideline, I think there is some statement somewhere that prior
26.
48 hours prior to the onset of stroke, the patient is on NOAX, it's a relative contraindication. That's what the recent thing says. But I think we have to be very careful when the patient is on NOAX. I think better not to give. However, if the patient is on heparin and only prophylactic dose, you can thrombolyze. Otherwise, if the patient is on heparin on full dose, we cannot thrombolyze.
Therapeutic dose.
Yeah,
No,
we cannot
there
thrombolyze.
also, if you can look at the APTT, less than 1.5 times it has not reached it, then you might give it. APTT will guide at that time.
Yeah. And one more comment is, I don't think there is any role of TE in such situation, because even if you do TE and demonstrate a PFO also, there is no indication for closure.
I think 90 years.
So I think the more important here is to chase the Holter again and again. And in such situation, it is always better to give beta blockers, because there are three ways of controlling the rate. One is anticoagulation, one is rhythm control, one is rate control. Among these three, best is anticoagulation. So you know in your gut feeling that it is paroxysmal atrial fibrillation, but you don't have evidence to it. So one way is if you give beta blockers, that will at least reduce the heart rate, and even if there is AF, if the ventricular rate is under control, they hardly ever embolize. So in such situation, the beta blocker may score over ACE inhibitors. Otherwise, normally we tend to give ACE inhibitors following stroke.
Yes.
That is one more thing. And one of the later guidelines now regarding this atorvastatin, it is always advisable to use ezetimibe along with this. The efficacy increases. I have seen personally maintaining all LDL strictly below 50. So the moment we add ezetimibe to rosuvastatin 40, the LDL really comes down. So once we maintain it at 40, because the incidence of intracranial atherosclerosis is very high in Indian population as compared to West. So there the targets are even more stringent. So I think better to keep atorvastatin 80 plus ezetimibe and strictly control the LDL below 50 and keep monitoring regularly. Then I think ezetimibe really helps. You can try that.
Sure, sure. I'll take.
An intriguing question I'll put across, just look at this. That supposing this patient we do a Holter, say we do even a 7-day, 14-day Holter, and then it is negative. Your approach will be to continue this patient on antiplatelet or just put on at least low dose of apixaban. Where would you stand?
I would put on antiplatelet only.
So, because here the chance of this being atrial fibrillation is very, very high.
Correct,
This
correct.
patient does not have a high atherosclerotic score, except the age. Nothing was showing up. If at all, it is only 2 areas of infarction, and that means we should consider embolus which has come. And at this age, it is going to be only cardioembolism. It has to be AF related. So why not a low dose of anticoagulation instead of antiplatelet? What is against that, Prachit?
No, low dose anticoagulation is basically, that means we are not anticoagulating at all. So we might as well give some antiplatelet. That is my logic. I don't know whether it is correct or wrong.
If you take the post-MI setting, River MI study, if you look at that, they do not go for that much high rivaroxaban. So they use it. So that is a logic I am trying to extrapolate here. The cardiologists use at the lower dose.
Correct.
And then they do with the triple therapy they go. So something like that I don't think we can prove it by any studies. I mean, we are not going to sit and do a study. In my practice, I use 2.5 mg twice daily of apixaban. Or offer the patient 110 mg BD of dabigatran. These are the two things which I offer. I mean, I tell them that it is not in the books. I mean, we don't have 100% this one, but this we think it is reasonable. You take it or you leave it. And believe me, most of them take it with both hands. You tell them. And it's more acceptable for them than to go for 30,000 investigation.
So,
practically, here, I think
our center, just a
small,
point,
what was the
at Triple M.
Yeah.
At Triple M, I agree that most of our elderly patients who have a cardiac background and who have a stroke, they are put on a small dose of apixaban 2.5 BID along with a single antiplatelets rather than a dual antiplatelet. And the cardiologists are quite happy, and we have not come across many complications of a bleed. So low dose NOAC, I think in elderly with the antiplatelet may have a benefit. I'm not sure about the dual antiplatelets along with the NOAC.
Just a question, madam. So, how long do you continue anticoagulant plus antiplatelet? What are you is it indefinite?
Yeah, it is usually indefinite.
Okay.
They continue. And we at our center, we are only doing a 7-day loop monitoring. So if we have a high index of suspicion of AF, then I think the cardiologists do continue, and we give a low dose antiplatelets, and that is continued.
Okay.
Unless we land up with some bleed, if because of a fall or something, then is a time when we have to reconsider our treatment.
Okay. And are we routinely prescribing the clopidogrel resistance assay in every patient of stroke, and possibly even prior starting clopidogrel?
No, sir, we don't have that. We are not doing it.
Is there a recommendation like that, sir?
No, I'm just asking, like, for my knowledge, because some of the cases we did the clopidogrel resistance assay, they came as intermediate metabolizers. I remember a couple of cases who were having recurrent strokes. So on the second stroke, it was done with a suspicion, and that came as an intermediate metabolizer, which means that the clopidogrel we were giving so long may not have been working. So then we shifted to ticagrelor.
Oh, there is one
One
problem
of
in
the
that.
recommendation today is to not to check for actually clopidogrel
Yeah,
resistance routinely, because it confuses in our practice. That thing came from the chance to data, I think. Is that correct,
Yes,
President?
I think,
Chance to
but
data it came from, but now it's a recommendation not to check them routinely, because
but
it
in a
completely
recurrent stroke,
confuses your
second time
practice.
stroke, even with
Yeah, only
dual.
in those special circumstances, yes.
see,
Prashant, you are telling something, sorry.
there is one issue in that. First thing is there is in vivo, in vitro difference. Okay,
Okay,
that is one thing. Second thing, just because a patient has got recurrent stroke doesn't necessarily mean clopidogrel is not working. Okay, so see, for example, if you see the secondary stroke prevention, there should be a lot of emphasis on strict LDL. Okay, many a times the LDL is not controlled. So if LDL is not controlled, if your BP is not controlled, if your sugar is not controlled, and still the patient is continuing to take clopidogrel, we cannot just assume that it's because of clopidogrel resistance. And if you see last 2 years, the for secondary prevention, we have to be more strict on blood pressure and less lenient on, lenient on sugar. So now sugar of 7 is very much acceptable. Okay, whereas blood pressure has to be strictly below 130/80. The problem is we do not have any average measurement for a BP. Most often it is taken, சார் நான் வந்து படிக்கட்டு ஏறிட்டு வந்தேன் பிபி அதிகமாக இருக்கு. They just leave it off like that. So those things are not acceptable. So BP has to be strictly controlled. So when these factors are there, it is very difficult to blame it on clopidogrel. I think considering all this, putting everything on clopidogrel as a resistance is a bit too much. So I think more important is to make sure that all the risk factors are adequately controlled. Your blood pressure, BP, cholesterol, diet, change in lifestyle, everything has to be done. Only then we can say that if after all this still clopidogrel, then okay, we can accept. So most often if you see the culprit is hypertension, even till today, the number one cause is hypertension, not diabetes.
sure.
Hypertension is the biggest culprit. Even cardiologists are struggling for this last 70 years. So we should be very, very
Sure, sure.
strict on blood pressure. That is the issue.
Regarding the extend IAT TNK trial, which you mentioned, an important point I would like to highlight in the data is that 10% of people in that data who had an LVO did not go on to require mechanical thrombectomy. Antiplace averted this. That is a Bruce Campbell only had quoted in your study. So Bruce
Yeah.
Campbell data, it says that it was not LVO 10%. They don't go for this. I mean, that's a plus point for Antiplace. Absolutely.
Yes, in fact, sir, there was a comment in that study, that part, that in fact, patients with the complete thrombosis of LVO had possibly, I mean, better benefit with the tenecteplase. There was some comment like that. I was reading through it.
So this patient, I think, is special because of the number one reason, more than 90 years. And in 90
Yes.
years plus, we usually think of having poor collaterals. But your clinical presentation with a very small infarct and a very big amount of deficits told us that this patient was one of those lucky patients who had good collaterals. That's why he survived through this and he has come out clean despite having so many deficits at the time of presentation. having a very small
Yes.
infarct, and the aspect should be almost 9, I think 8 or 9 should be there. And this
Yes,
patient has really
yes.
come out well. That's one lucky thing which you had through. Anyway, thank you for
Yes.
presenting. If there are any other comments regarding this case, sir? Prachit, any other comment to be
No,
mentioned for this?
that's fine.
And any other points, anything, madam, you want to discuss, madam?
No, sir.
Jayanti, madam.
I'm no. It's a very good case for us to learn. I'm quite happy. Nothing more to add.
Thank you.
Thank you, madam. Anirban, sir, anything else you want to tell us, sir?
No, sir. I think I've
Thank
presented
you.
my
I think
case.
we'll hand over
Thank
the Prachit.
Yes.
We'll hand over the session back to our organizers. MCure people, thank you very much for hosting this wonderful program and inviting us for this talk. Thank you very much for allowing us to participate in this program. Thank you, madam. Thank you, sir.
Thank you. Thank you, sir.
Thank you, sir.
Just if you can.
Thank you.
Could you
Sir, please go ahead.
Sir, this is the KT Live, which is marked after a webinar, after the a new stroke guidelines. We have touched upon many points on the stroke guidelines also in this. I think we'll also have a much more discussion which has to be done on this. So, but on this thing, on behalf of the entire team Gennova, we extend our heartfelt gratitude to, first of all, to Dr. Meenakshi Sundaram for graciously serving as the course coordinator for today's KT. And we also sincerely thanks our esteemed moderator, Dr. Prachit and Dr. Jayanti ma'am, for sharing the discussion with clarity and precision. Our deepest appreciation goes to Dr. Anirban Laha also, the speaker for today's program, for sharing their expertise, insight, and clinical wisdom. So we are confident that all the delegates have been immensely benefited by the knowledge shared by this distinguished faculty. Thank you once again for everyone who made this session successful, and have a great